I now invite Shilpi to come and give her, she'll show you beautiful videos done on Ingenuity, and it'll be a treat to see. So she and Prashant have been kept for the last, along with Dr. Somil, who's not here, but he sent his presentation. So I'll play it after Shilpi's. She's from Sarakshi Netralaya, and she and Prashant are working together.
Thank you, ma'am. Good morning, everyone. Thank you, Kerubi ma'am, for this wonderful opportunity. So, I will be sharing my top 7 pearls for managing giant retinal tears. So, we all know giant retinal tear is always a nightmare for any vitreoretinal surgeon because of the less chances of success. So, in giant retinal tear, we all know that it is more than 3 clock hours of the retinal tear. Edges have the tendency to roll back, but yes, with the advancements, we have improved success even in cases of giant retinal tears because of the wide angle viewing systems, use of PFCL, smaller gauge vitrectomies, high speed cutters, and vault cannulas. So, the pearl one is PVD, that is posterior vitreous detachment. It is usually present in all the cases of giant retinal tears except when there are cases of trauma or familial vitreoretinal degeneration. So this is a case where PVD was not present and there was no space. So initially you need to create the space by draining out the fluid as much as possible, remove the membranes over the posterior pole, and then when the space is created, PFCL is put and the case is closed. Second pearl is base excision. It is very important in any case of retinal detachment and especially in case of giant retinal tears. We should always use high speed and low vacuum while doing the base excision. Base excision can be done by the depression also and the interface excision also. In this case of GRT, we not only do the base excision on the area of the GRT but also in the other quadrant so that all the traction is relieved. And if you feel that some traction is still remaining, you do the base excision especially in the area of the giant retinal tears, and the rest of the retina and the vitreous is cleared. Third pearl is management of the anterior flap. Why anterior flap management is important? Because it is a devitalized tissue which is a scaffold for the anterior loop PVR and it causes rubeosis. So we can manage it in two ways. We can excise the flap or we can laser ablate it. So in this case, the anterior flap, it was excised because it is a devitalized tissue and it is of no help. And if you feel that you cannot remove the full flap, you can even depress and then remove the flap. Despite that, if you have done the meticulous dissection and you have tried to remove the anterior flap completely, but sometimes there is some tissue remaining despite of the meticulous dissection, and in that case you need to laser the remnants of the anterior flap so that it will not cause rubeosis or the PVR at the later stage. Now coming to the fourth pearl, that is the unfolding of the retina. In many cases when there is a large GRT, there is like you can see here that there is the retina is folded on itself. So after unfolding you can use PFCL. It should be injected over the disc as a single bubble till edge of the GRT, and you always have to tilt the eye in the opposite direction so that the SRF is drained. So these are the cases. In this, it is almost 270 degrees giant retinal tear. After unfolding the retina with the two instruments, that is the light pipe and the cutter, the PFCL was put as a single bubble over the posterior pole, and after it is flattened, it was managed as a routine GRT case. Despite putting the PFCL, there was a retinal fold in the periphery. So we can use the ILM forceps or the soft cannulas or the blunt tip of the forceps so that we can unroll the flap and after unrolling the flap we have to complete the case as a usual case. So in this case there were membranes. So after removing the membrane, PFCL was put Again, the anterior membranes were dissected. If needed, we need to do retinectomy so that we can flatten the retina and then the case can be completed. The fifth pearl is how to do the laser. So retinopexy is most important, and we have to use the moderately intense burns. It should be near confluent, and always 3 to 4 rows of the burns should be given. We should not leave the horns or the radial extensions, and always put the extra rows of lasers in that case. Usually in cases of GRT, the endo laser we usually done under the PFCL because there are less chances of slippage of the flap. So there was the horn left and the anterior flap also, which is being lasered. Now, how to prevent the posterior slippage? So always avoid high and broad buckles. You should always put the PFCL up to the edge of the GRT. Meticulously, we should remove all the subretinal fluid. In that, you have to rotate the eye in the opposite direction or the dependent position so that it removes, and always do the repeated drainage along the edge of the GRT. If needed, you can do PFCL silicone oil exchange, but if you have done your lasers well, if the retina is well flattened, even the fluid air exchange with the silicone oil exchange is equally successful. So these videos will show how the drainage is along the edge of the GRT is done. Always remember, never cut short this step. This is one of the most important step. You have to give extra time while draining the fluid along the edges of the GRTs. You have to repeatedly do the fluid air exchange so that the last bit of the fluid is removed. Even in cases of 360 degrees of the GRTs, we have never done the PFCL silicone oil exchange. It is always the fluid air exchange and the silicone oil exchange. Now, you always have to tackle the concomitant pathologies also, like like ERM and macular holes. So after putting the PFCL and staining the ILM with the BBG dye, the ILM was peeled under PFCL and the case was completed later. And this is a case where there was a macular hole. After relieving all the anterior traction and creating the space, the ILM was stained, fluid was drained, and similarly the ILM peel was done and the case was closed. But remember, many a times it's not your day. Even after meticulously dissecting all the membranes, clearing all the anterior flap, doing the lasers and everything, there is some kind of residual things which are left. Like if you see that at the end of the case there is some fluid pocket over the macula, but don't panic. Over a period of time this fluid resolves and there is no recurrences in such cases. In this there was a slippage of the flap and the PFCL bubbles went besides the retina. During the fluid air exchange you can remove this PFCL bubble and again put the PFCL later on and complete the case. And in this case, even after removing the complete PFCL and the fluid exchange, there was a little fold over the posterior pole at the last. But after putting the oil and giving the proper position, these folds later on they get settled. So thank you so much.
Wonderful cases, Shilpi. It was a treat to see. Only thing is that tell me that when you're working on the ingenuity, do you have a learning curve? Or is it like cakewalk, like you go in and you see a large thing and it's very easy?
It's only a learning curve because of the lag, and it was only for a 3 to 4 or 4 to 5 cases at the max.
Okay, okay. Because the thing is that every new thing you have to adapt to it. So I just wondered like what would be the adaptation to the Ingenuity. Any other questions? Come to the mic. And you said that after doing these things meticulously, if still there is something remaining behind, blame it on the patient's karma.
I'm sorry. Good morning. My
Good
question is
morning.
regarding the ROP, open sky. How do you maintain the vitreous cavity during those times of
Sorry,
the during the time of open sky
yes,
vitrectomy in ROP stage 5?
yes.
How do you maintain the vitreous cavity?
How?
Maintain the vitreous cavity. Do you
I
have
had
a
put a Fleringa ring around it. I had put a
viscoelastic? You use
I
viscoelastic.
put a Fleringa ring first.
Mhm.
If you saw the Fleringa ring which was there,
Okay.
so I had sutured that onto the sclera, so it holds the eye up like a embroidery a thing, you know. I mean, the band which is there, and then the assistant has to keep injecting PFCL, not PFCL, this
Viscoelastic.
viscoelastic substance every time you're
You
this and
dissect.
yeah inside the eye.
Okay, thank you.
In giant tears, before you put the oil, you shift to air from
Yes,
the
sir.
PFCL, or you do direct PFCL
No,
oil
sir, no
exchange?
direct PFCL or silicon oil exchange. It is always PFCL air exchange and then the silicon oil.
No, but you can do PFCL
Yes,
silicon
sir.
oil exchange. That sometimes solves the problem of repeated slippage.
Mhm.
And also the edge can be very stiff and there can be edge PVR. So some radial nicks at the edges sometimes will help it prevent roll.
Preventing
The edge may not roll that much.
That is the reason why, if you have worked with the stalwarts like Dr. Badrinath and all before, they used to do the giant retinal tears in prone position, where they used to be sitting under the table and doing the air injection so that you know it falls into place like an umbrella.
That is when the retina becomes stiff. That will happen, and shortening. So even after you have put PFCL, it won't go and settle in its place because it is shortened. Then you may have to give radial cuts. Be sure that you have done laser at the posterior end of that radial cut. Otherwise, it will extend and you will be in trouble.
I've seen Dr. Badrinath do a buckle at those radial edges of a 90 to 100-degree giant retinal tear, and it settled.
It settles.
Yeah. So it depends upon whether it's a fresh GRT or it's
Old
one
GRT.
with PVR. So in a fresh one, normally doing a good base excision is the most important thing, particularly at the edges. So either you relieve traction from inside or outside or both. And when it's a PVR, then of course you treat it like any PVR, and then you may extend the GRT also and do retinectomy or whatever. So remove all the contracted part, because there are two elements to PVR. One is the membranes on and under the
Paritosh,
retina
speak
band.
into the mic.
And the other is basically the intrinsic contracture of the retina. For intrinsic contracture, you'll have to cut the retina. Others? Yes, so there then you have the choice.